Hi everyone, this is Mikhael El-Chami for Heart Rhythm TV, and it's pleasure today to host Dr. André Zimerman and Dr. André Davia. Dr. Zimmerman recently presented the PhysioSync-HF at ESC in Madrid, and this trial had a lot of important implications and a lot of opinions among the EP community. Dr. Davila was on the steering committee and an author on the trial as well. So we will start with Andre and Andre. Hi guys, how are you?
Good to be here. Thank you for the invitation.
Thank you. Thank
Yeah,
you for coming.
likewise.
Thanks. Great. So, Dr. Zimmerman, I'll start with you since you've presented the trial recently, and I can share this. We can share the screen with the slides whenever it's time. Um, but can you tell me a little bit about the trial and what was the background of the trial a little bit, and the inclusion criteria and the outcomes? And I can try to share the slides at some point.
Perfect. Well, again, thanks so much for the invitation. It's a very nuanced trial, and it's important to have these moments to really get a chance to discuss our findings. So, the motivation for this trial is that we know that biventricular resynchronization, traditional resynchronization, helps patients with heart failure with reduced ejection fraction, left bundle branch block, but we know that conduction system pacing has been proposed as a better way to resynchronize these patients, potentially leading to better outcomes at a lower cost. So we attempted to study this in a randomized trial, specifically in the Brazilian setting. And our goal was to see if conduction system pacing was non-inferior to biventricular pacing in our population, and if so, to see if it was superior to reduce cost. So we included patients with symptomatic heart failure, NYHA classes 2 or 3, with the left ventricular ejection fraction below 35 and left bundle branch block with a QRS above 130 milliseconds. And these patients were randomized to either conduction system pacing or biventricular pacing. So importantly, conduction system pacing was a strategy. The preference was left bundle branch area pacing, but if not possible, the operator would then sequentially go on to his bundle pacing, deep septal pacing, and if none of these worked, then LOT CRT with a lead in the coronary signs. And the endpoint was measured at 12 months, so every patient was followed for 12 months. And the primary endpoint was a hierarchy of death, hospitalizations for heart failure, urgent visits for heart failure, and change in left ventricular ejection fraction. So every patient contributed to the primary endpoint. Those who did not die or experience heart failure events were categorized according to their change in LVF, so encompassing both clinically relevant endpoints and echocardiographically relevant endpoints. So basically, this was the trial population design and endpoints.
And this trial was predominantly in Brazil, right? Around 14 centers, if I remember correctly.
Exactly. So this was a trial that was funded by the Brazilian Ministry of Health. So we have to understand the results in light of that. It was a much more pragmatic trial than other previous studies. We had 14 sites in all regions of the country. So if you see our baseline population, we had 173 patients enrolled. Half of them were women. Most of them were non-white, which really reflects our population. And we see that 2/3 had a non-ischemic dilated cardiomyopathy, which also is in contrast to some of the earlier trials. It's important to understand the population in which the study was done to interpret the results. Our patients also presented to the hospital setting at a later stage. So the median QRS at baseline was 180. Most have, or the vast majority had typical left bundle branch block, nearly 100%, and most were on guideline-directed medical therapy for heart failure, over 90% with AC inhibitors or ARBs or Entresto, 90% with beta blockers, over 80% with spironolactone.
And I think there was a slide that we skimmed on quickly that it's important to mention there was no loss to follow up and no one withdrew consent. So all these patients were followed for the duration of the study.
Exactly. Yeah. So I guess now going to the procedure and then to the primary endpoint. Regarding the procedure, there was no difference between the two arms in the duration of the procedure, 120 minutes median for both. For patients randomized to conduction system pacing, the lead was placed in the left bundle branch area in about 2/3 of cases, followed by his bundle pacing in 2%, deep septal in 18%, and lot CRT in 8%. And we had few crossovers, less than 10% of patients crossed over from each side. And then going into the specific EP parameters, so we believe that our resynchronization parameters were adequate. The median R-wave peak time in V6 was 83, V6V1 interpeak interval 42, and then for the biventricular pacing arm, the QLV was 121. So I know this has generated a lot of discussion, and we can come back to this further. The QRS change from baseline was minus 60 milliseconds with the conduction system pacing arm, so that was also a good improvement.
So I think, and it's important to mention it maybe here, like some of the criticism, to me, it's not a criticism, but some of the criticism is that patient enrolled in this trial maybe were biased to benefit from BIV, right? It's the women, predominantly non-ischemic cardiomyopathy and a true left bundle. So if you take all comers to get a BIV, these are the people you expect to respond, to be responders to CRT. What would you guys say about this?
Yeah, so I can start. First, I'll talk about the primary endpoint, which is a slide you have here, just to get listeners up to speed, and then we can talk about potential explanations. But the primary endpoint basically shows that conduction system pacing was inferior to biventricular pacing, and was inferior with a directionally consistent effect on every component of the primary endpoint. There were more cases of death, more cases of heart failure events, and an attenuated improvement in left ventricular ejection fraction in patients randomized to conduction system pacing. And as you say, there are multiple reasons that could explain this result. And this is one. We had a population that is typically a population that responds very well to biventricular pacing. We had 50% women. We had most non-ischemic cardiomyopathy. We know these are hyperresponders to BIV, and not necessarily these patients will also be hyperresponders to conduction system pacing. So again, it's important to interpret our findings, which were unexpected to us as well, in light of our patient population, which was somewhat different than those from previous studies.
And this is some of the other outcomes in terms of the ejection fraction improvement.
Yeah, but this is an important one, right? It shows that there was a significant improvement in both groups.
Yeah.
But the BIV group did better in several aspects of the trial, including, we went over that quickly, but the number of patients who had an improvement on ejection fraction that was equal or more than 20% was way superior on the BIV, which counts for the final results and interpretation of the trial.
Can you comment a little bit on something maybe I didn't understand from statistics perspective? Why the hierarchical primary endpoint? Most of this randomized study I see, it's a combined primary endpoint. Why did you guys choose that kind of endpoint?
So the idea here was because we knew we would not be powered with this number of patients, would not be powered for a true cardiovascular outcome study, which is, of course, ideal. But then we would need 2,000, 3,000, 4,000 patients to do these outcome trials in which we only counted as endpoints, say, death and hospitalizations for heart failure. So here we tried an endpoint which gives us more information, understanding that death is worse than hospitalization, which is worse than, say, a decrease in LVF, which is worse than an increase in LVF. So we categorize patients according to this, basically a rank in terms of an endpoint. But of course, this does not replace a dedicated outcomes trial that will come in the future, such as the left v left study. But the idea here was to have every patient contribute to the primary endpoint in a way that included both hard endpoints and the echocardiographic one that is a validated surrogate for heart failure.
Before we go to more questions, any other slides you'd like to share with us? I know this is not a full presentation, but if there's any other important slides you think it's important to go over before we continue our discussions, that would be great. Let me know.
Yeah, I think there are two ones to highlight here, and then we can go on to the discussion, and then, of course, André Davila will chime in way more. But first, for the secondary endpoints, we did not find significant differences in most secondary endpoints. LV and diastolic volume was similar. The final QRS duration was similar. BNP and NT-proBNP, KCCQ, which is a marker of quality of life. All of these improved markedly in both arms and in a similar magnitude. Curiously, the improvement in the 6-minute walk distance was slightly greater with conduction system pacing than biventricular pacing, and as expected, cost was way lower with conduction system pacing. And then the next slide, which also is important in terms of safety, we had more procedure-related complications in the CSP arm, 10 patients versus 7 in the BIV arm. And importantly, we had 3 procedure-related deaths, all in patients initially randomized to conduction system pacing, but one of them occurred after crossover to biventricular pacing, which was also a rate that frankly surprised us and surprised the trial operators, which also mentioned that this was way higher than they had been used to in their own experience. But this was an important factor that happened during the trial. I think these were the main points to discuss.
So in terms of the death procedure-related, was this procedure-related death, meaning that it was a mechanical complication, or it was just death during hospitalization for the procedure?
No, so these 3 were mechanical complications. One of them was likely a tamponade that was not seen in the postoperative ICU, and the patient went on to develop pulseless cardiac arrest. A second was a tamponade probably due to right ventricular perforation. And the third was in an attempted cannulation of the coronary sinus after the patient had crossed over to biventricular pacing. They developed tamponade and went on to
the second, this RV perforation was actually, the patient came to the hospital and over the weekend developed like a complete AV block and requiring a temp wire. And the temp wire perfed the RV, which resulted in surgery. And after that, patient had several complications, but the patient had already been randomized to CSP. Okay. But one important point is this: even if we were able to remove those 3 procedure-related deaths, the trial would remain inferior. CSP would remain inferior to BIV in this specific population. Of course, we can't do that, but just as an exercise.
As a sensitivity analysis, that was an important one.
Well, I think this trial is very important and very interesting because to me, as an electrophysiologist who's been doing CRT for a long time, I felt that leap into conduction system pacing was a little bit maybe too fast for me. And in my practice at this point, those patients that are typically would benefit from CRT, like the true left bundle, the non-ischemic, I still go with CRT first, but maybe I'll start with André Davila. Would this trial change the way you practice, or would this trial make you just leave maybe conduction system pacing for people who cannot get a good LV lead in? Or how would you interpret this trial? How would it change your practice?
Yeah, before I answer your question, I'd just like to emphasize one important point. We were very enthusiastic about CSP. That's the whole idea behind the trial, because if the CSP was non-inferior to IV, it would result in a significant change on the Brazilian practice. All these patients are from the public sector, and that would save the Ministry of Health millions and millions and millions of dollars, and yet providing the same kind of quality of care. So that was the inspiration behind the trial.
Yeah.
And because of that, the EPs who were performing these procedures were not only enthusiastic about CSP, but they were also very experienced EPs in both with IV and in CSP. And you have to think about this trial as a phase 4 trial. It's almost like we are trying to test a strategy that is out there. And surprisingly and unexpectedly, we got as disappointed as everybody else, but the data is the data. There's nothing we can do about it. And some of the concerns was that, well, what if you lose left bundle capture during the follow-up? But that's exactly why the trial was designed. So it's not fair to say, well, CSCP is only good when left bundle capture remains intact for the next 5 or 10 years. That's the hypothesis. But what happens in practice in the real world is that today you capture the left bundle, a month later you lose capture. And that's exactly what the trial was trying to evaluate. Because of that, we had to change our practice. We started let's say, the journey in terms of conduction system pacing in 2016. And I think we have a very good experience in different modalities of CSP, including by IV. But now when we have patients just like the ones evaluated during the trial with like advanced heart failure, very long QRS durations, we have a very, very low threshold to go LOT CRT. So if we don't have an absolutely perfect left bundle capture criteria, we now have a very low threshold to add to that septal lead a CS lead. Because one of the important things that we didn't talk a lot about the trial is this: when we show the improvement in ejection fraction in different categories, if you just do like a very rough cutoff, let's say more or less than 5% or 10%, you wouldn't be able to appreciate the number of super responders that BIV had in this specific population. It's not actually fair to the technique to simply go above 5 or above 10%. If you categorize the improvement in different, like by 10% improvements, this is when you see how BIV did much better for the group that we're able to study. So I think we need, as you said, right, what it's clear here is that when you have a population, a diverse population, perhaps CSP may not be the best solution for all the groups out there. And we need to stop and think over our strategy and perhaps over our more individualized approach for these patients with advanced heart failure and left bundle branch block.
Yeah, thank you for these very important comments. I think just for the audience, the group, it's important to mention, as you said, that the group participating in this trial were all experienced in conduction system pacing. Because some of the comments I've seen on Twitter is 18% deep septal pacing, or I forgot the percentage, but some of the criticism, well, not everyone, left bundle branch area capture was not achieved in everyone, but maybe what we should learn from this is the real world. Like, you can achieve left bundle branch area pacing in everyone. And another important point you commented on is we don't know if you lose left bundle branch area capture during follow-up. So, but this is the real world as well. Were you guys able to evaluate consistent conduction system capture during follow-up, or that was not looked at?
So it's mandatory to do a unipolar pacing threshold test at 6 and 12 months. So we're doing the sub-analysis as we speak now.
So right now in Brazil, for you guys, if you have a dilated cardiomyopathy, left bundle branch block, you've changed your practice to go from maybe conduction system pacing first to CRT or LOT CRT rather than just traditional CRT.
Well, I can tell you about my group, right?
Mhm.
So we, because of all of this and several criteria in terms of how to better define capture, we've been using TEE for most of our CSP patients. So I know exactly where my lead is. And if my lead is where it's supposed to be, and yet I don't have a perfect left bundle capture criteria, we would immediately switch and offer this patient a LOT CRT. Another important question that I'd like to comment is that, as you notice, there was no ICD implants in the trial, even though the population was like a classic indication for ICD. It is and it's not. So, we had 3 sudden deaths during the whole year of follow-up, right? What's interesting is that, think about this, the mean ejection fraction was 27, and the mean improvement was 10%, roughly, which puts them outside the ejection fraction zone of ICDs. But what's important, the reason for us not to go with ICD in this population is because in Brazil, due to a cost-effective analysis done 10 years ago, primary prevention with ICDs is just not done. It's not, the Ministry of Health does not cover the cost of primary prevention with ICDs in this country. That's why the study was designed as Dr. Zimmer just presented.
So, and that's interesting to learn. So even the ischemic cardiomyopathy, EF less than 30, no primary prevention?
There's no primary prevention. And we are revisiting that with a different trial because, of course, we disagree with that. But as we speak, we cannot simply implant. And because these are public patients, we have a universal medical system here. This is all paid by the government, and they simply do not cover the cost of primary prevention ICD.
That's very interesting. Thanks for sharing that. Any other comments you guys would love to add to this trial?
No, I think honestly, as Andre has mentioned before, we were not expecting these results. We designed the trial thinking we would find something else, and now it's an interesting scientific exercise to understand why we saw this. And we think there are 3 main possibilities. One of them is simply the patient. As we have said several times, these are patients that are different, more women, more non-white, more dilated ventricles, non-ischemic. It's a different patient population, particularly hyper-responders to biventricular pacing. So this is one. The second issue that I think is critical is that in this trial, we had blindly adjudicated endpoints. So every echo was analyzed by a blinded committee. Every heart failure event death was also analyzed by a blinded committee. So we did not have bias in this sense. And the third reason is, again, the experience of the operators and the healthcare system. We, of course, as in anywhere in the world, people are more experienced with biventricular pacing than conduction system pacing. Even in our trial, our sites were heterogeneous. Some had way more experience than others. In a, let's say, crude subgroup analysis, we did not find any signal suggesting that the effect was different, but this could be an explanation. So now we really need to dig in and try going beyond the primary results of the trial to really understand these results and think, what would have been differently for patients with typical left bundle branch area pacing. Would it be different to help to create data to inform future studies and help us understand what the role of CSP will be?
I think what's telling about this trial, or to me, that the CRT arm and the conduction system pacing arm both had significant narrowing of the QRS. I mean, 126 with the CRT, that's an amazing narrowing. And 120 in this population with a wide QRS of 180 at baseline with conduction system pacing tells me that both arms, you guys achieved what you needed to achieve for the ballpark. Yet still, CRT patient seems to have done better. So I think this trial was very important. And maybe to me, it will put pause for conduction system pacing in this particular population, the population that really is supposed to respond well to the traditional CRT system. Go ahead. I was going to say any final comments.
Yeah, I fully agree with you, because that's exactly what we need to do now. We need to understand what kind of subgroups will benefit better from CSP. And it seems that advanced heart failure, especially in non-ischemics with a predominantly population of women, we need to look at this in a different way for sure.
But thank you both for giving us some of your time to discuss this important trial. It definitely resonates a lot in the EP field, and what's surprising to us as it was surprising to you all, but it's important. Thank you for doing the job, and because this needed to be done. I appreciate you and looking forward to seeing this episode online.